everyone. Welcome to COMHE 330. This is Introduction to Epidemiology. Today's lecture is going to be on the introduction to and history of epidemiology. Basically, I'm going to go over a lot of terminology, try to get us on the same page to start off the semester. Make sure we're talking about things in the same way. And then talk a little bit about the history of epidemiology and finish with a few slides on how to interpret a scientific article. And then at the end of this class, you're going to have a couple in-class assignments, more on that later. So I am obviously not here today, and I won't be here for the entire week, but I will be available on email, and I'm hoping that you guys send me any questions that you have about the lecture, and this is important because you're going to have a quiz on Thursday. So if anything in these recordings doesn't make sense, shoot me an email and I can make another video quick, or I can arrange something so that you guys are getting the information that you need, and we make sure that you feel prepared for the quiz later this week. So sorry, I'm flipping back and forth between screens on my computer and trying to make sure that you're seeing what I'm seeing. Great, okay. So the first couple things, if you don't have access to Blackboard yet, shoot me an email so that I know to send you all the material that I've prepared, or ask one of your classmates to download things from Blackboard and send them to you. Either method works. If you want me to do it, you need to email me. If you're going to have your classmates do it, then we can figure out Blackboard when I get back at the beginning of week 2 of class. All right, so next I'm going to review the syllabus with you. And first I'm going to change my screen so that you guys see the syllabus. And I think right now what you probably see is a picture of my sister and me from my Google Plus profile. All right, share. Okay, so you should now see the syllabus, and I'm just checking it on my computer to make sure, yep, that you see what I see. Okay, so you guys are obviously meeting in room W610, I hope, or maybe you've moved. And my email is here. Feel free to email me anytime. Office hours. Available by appointment. I will make myself available to students before and after class, but you need to email me before time so that I know to come early to meet with you or to stay late to meet with you. I will be using Blackboard for this course, and the book that you're going to be using is Epidemiology 101 by Fries. DOHMH EpiQuery, you're going to use quite a bit for the morning session. And NYC Open Data is related to DOHMH EpiQuery. I think actually Aaron will cover all those things for you. You're going to use DOHMH in this class a little bit to pull data for some of your projects. All right, so these are the learning objectives. Basically, you're going to be able to give an oral critique of an epidemiological as well as an informed written critique of an epidemiological article. And what I really want you guys to get out of this class is to be able to understand study design and some of the biases that happen in epidemiological studies, and just differentiate between the different types of study design, as well as distinguish between different sources of data and the advantages and limitations, and to identify like what descriptive variables are relevant to analyze population-based differences in health outcomes. So how am I going to assess these? Basically, you're going to have a midterm, you're going to have a final, you're going to have a written a survey and survey results that you turn in, as well as some little assignments that I'm going to give to you as we go along. So let me go over those. All right, so the midterm assignment for this class, the main way I'm going to evaluate you is by this health condition project you're going to do. And what that means is at the end of class today, I'm going to ask you to fill out a form. And what you're going to do is submit to me two choices of a health condition. So I have a form. It has a list of pre-approved topics you can study. And you're going to select your first pick and your second pick. And then what I'm going to do is I'm going to make groups. And you're going to work with this group of your peers for the rest of the semester. And you're gonna come up with for the midterm, you're gonna present on this topic. So let's say you pick school bullying as your health condition that you're gonna study. For the midterm, you're gonna give us, your classmates and I, a presentation on school bullying, and you're gonna conduct a literature review. And in your presentation, you will turn in you're going to identify research questions that you want to answer. So there's two things that you're going to turn in for the midterm. One is a PowerPoint presentation, and the other is a Word document. And the Word document is going to be your literature review. The second part of this health condition topic that you're doing all semester is data collection and analysis. So to start, you're going to have to develop a survey, and you're going to survey people about your health condition. So maybe if your health condition is school bullying, you're going to ask people about risk factors for bullying. So these could be, maybe you think that depression is a risk factor for being bullied, or maybe you think that sorry guys, I'm turning off my phone. Maybe you think that being overweight or obese is a risk factor for bullying. So you're gonna come up with a survey, and you're gonna ask people about these things, whatever your risk factors are and your health condition, and then you're gonna distribute this survey to 50 people, and then you're gonna get responses from them. We're gonna analyze the data, and you're gonna write a report. So this is the data collection and analysis. So you're going to turn in your data collection instrument for a grade, and a report of your analytic findings. So this will be a Word document. And your data, you're turning in your data so that I can check and make sure the numbers that you're reporting are the numbers that I see in the data. Now the third part, you're going to take the results of your data collection, and you're going to turn it into a final presentation. So you're going to tell me what your results mean. So what you would recommend to the community based on these results. You know, maybe you found really high rates of bullying, or high prevalence of bullying among the 50 people you surveyed, and you think that what should happen is that schools should offer more resources for students who are bullied. And then sort of identify like what should happen next, the next steps for further research. So in addition to this health project you're going to do, we're also going to have quizzes, readings, and some small homework assignments that you have to turn in. Now these will not be, so those first three assignments, your midterm, your data collection and report, and your final, these are going to be group projects. But the assignments, the quizzes, the readings, and the homework, you're going to do these as an individual and turn them in for a grade. The other thing you're going to be graded on is participation. So I want you to be on time and prepared for class and ready to participate. So this class is going to function as a community of epidemiologists, and your voice is going to be crucial for this to succeed. So I want you to come and be ready to engage in class discussions, refer to readings, and ask questions. Half of your participation grade will be based on your attendance and participation in the morning session. So Erin, your teacher for the morning session, will give me a grade for your participation and attendance for morning, and I'm going to incorporate that into your final course grade. All students are going to be asked to be a class discussion leader. And a portion of your participation grade will be based on your preparation for and leadership of the class discussion. So this week, while I'm gone, I've already asked some students to be class discussion leaders. I just randomly picked the students whose names are at the back of the alphabet. So I sorted my student roster in descending order by last name, and I've picked those students to be class discussion leaders this week. You have or will be getting an email from me with your instructions for being class discussion leader. Now grading. So class participation is 10% of your grade. That's actually a pretty big chunk. So if you had a B in the class, but you got 100% for participation, that would move you up to an A. Assignments, homeworks, quizzes, and readings are 20% of your grade. The midterm is 25%, the data collection and analysis is 20%, and the final is 25%. So these are the letter gradings and the systems for grading. This is standard for Hunter. Withdrawals, you're of course allowed to withdraw. You need to notify me if you're doing so. And grades of incompletes will not be granted unless the request is justified by legitimate and documented emergencies. Appeals, you're always allowed to appeal your grade, and there's a link here to do so. Now, course policies. Attendance and class participation. I'm going to excuse up to 1 absence. Beyond that, you need to check in with me. This class moves fast, and I actually think it's pretty hard to pass this class if you're going to be gone quite a bit. So a student who arrives more than 5 minutes after the start of class will be considered late. So make sure you're on time for class. Late and incomplete submission of assignments. Assignments that are turned in after the due date result in a 10% loss of credit per day. So if you had 100% on the assignment, you turned it in a day late, you're down to a 90%. You turn it in 2 days late, you're down to 80%. More than 3 days late, you receive a failing grade. Makeups, rewrites, and extra credit. In general, I don't allow extra credit. I will, though, give participation credit. Participation credit can be made up through extra credit. So, and this is only at my discretion. If you have to be gone, and I do understand it's summer, sometimes people have to be gone, you can make up those points via extra credit. So what do I expect from you? I'd like you to stay off your cell phones and to refrain from personal email and texting during the class. I will also not be on my cell phone because I'll be talking to you. If you have an emergency, of course, excuse yourself and use your phone. But try to avoid distracting other students. Students who are on their phone consistently during class will lose participation credit. Students who are drawing in their notebook consistently during class will lose participation credit. I just want you guys to pay attention and be engaged. And also remember, this class is going to have a lot of discussion, and you need to be considerate of others when they are speaking, including myself, and I will also be very considerate of you guys. So what should you expect from me? I will provide specific guidelines, due dates, links, etc., everything for every assignment, and I will provide that no later than the class before which it's due. So if I give you an assignment instructions on Tuesday, it would not be due, so you would never have to turn it in until the next day. I will also provide you with my grading rubric for the main assessment. So this is the midterm, the data collection, and the final. And this just allows you to understand how I'm going to be grading things, what I'm looking for, what I want. And I will make sure that I will return all graded assignments within 1 week of submitting it to me, and I will include explanations for lost points. I think that's a really great way for you guys to learn, is for you to understand why you were missing points. The other thing to keep in mind now that I'm thinking about points is we're going to use AMA style references. It is like the easiest way that students lose points. So just make sure whenever you're turning anything in with references that they're referenced appropriately. All right, so now on to the course schedule. So this is a tentative course schedule. There's going to be times when we need to dive deeper into a particular subject, in which case this timeline has to change. The most up-to-date version of the schedule will always be available on Blackboard, and updated items will always appear in red. You'll see nothing's in red right now because I haven't had to change anything. All right, so just some important dates. So this week, quiz on Thursday. Every Thursday, except for the last week, you're going to be having a quiz. So second week, quiz on Thursday. At the beginning of the second week, I'm going to assign your midterm and the data collection, and later in the week, I'll assign the data collection assignment. At the beginning of the third week, you will present your midterms. Again, the class moves fast, so you're going to have a week to do your midterm. Generally, students have, probably about a month when this is a full semester. You guys are doing this class in 5 weeks though, so things have to move fast. And I have to make sure to give you guys enough time to get out and survey people, do your data analysis, write up your data analysis. So at the beginning of the 4th week, week 16, actually, I guess it's the 5th week, you will have to turn in your data analysis report, and your final presentations will be on the last 2 days of class. Again, midterm presentations, final presentations, data analysis, and report, all of this is going to be a group assignment. And if people are having troubles with their groups, you should, keep me updated. Let me know as we're going. All right, so now I am switching back to the lecture slides. Okay, so we've reviewed the syllabus. You have my email. I'm away, but you can reachable by email. You have a quiz on Friday that you can use calculators for. The other thing, housekeeping part 2, class discussion leaders today. Michelle and Liliana, I actually think, I just heard from one student and I think he's already dropped. So you two are the class discussion leaders. I might try to loop someone else in, but for now, we have 2 class discussion leaders. And at the end of this lecture, the class discussion leaders are going to give you 15 to 20 minutes to review an article, and then you're going to spend some time as a class completing a document, and then you're going to submit it to me. The class discussion leaders will write down the class responses and submit that document to me, and they're going to submit any questions that you guys have about this article that I'm having you read, as well as any questions that you have about the lecture. Individual students should also feel free to email me if you have questions. Now, each student, in addition to the class document that's being submitted, each student should submit a Google form with the first and second choice of held topic and complete the scholarly article form and submit that via Blackboard. You'll complete the scholarly article form for the article you're reading as a class, so it's not going to be an excessive amount of additional work for you. All right, so what are we going to learn today? First, I'm going to talk to you about the history. So first, actually, I'm gonna define a bunch of terms. So you're gonna learn the difference between endemic, epidemic, pandemic, conditions, and diseases. Then I'm gonna go over a couple current and historical epidemics, outbreaks, and pandemics. There's gonna be more definitions. You're gonna learn the difference between descriptive and analytic epidemiology. You're gonna begin to understand how to interpret an epidemiologic study. I'm gonna go over some famous people in the history of epidemiology. And you're gonna see your literature review table and how that needs to be completed. Okay, so, all right, so when you hear the term endemic, what does that mean? So the definition in your book is the constant presence and or usual prevalence of a disease or infectious agent in a population within a geographic area. The way I like to think of this is it's the baseline level of disease. So there's always some amount of disease in a community, right? So there's, at any given time in the year, there's always a certain number of people who have influenza. In the winter, we see that number spike. But generally, there's still, all year long, there's going to be a certain number of people who have the flu, or there's going to be a certain number of people who are living with HIV, or a certain number of people who have tuberculosis. These are your baseline levels of disease. And if we look at the endemic disease on a graph, I actually think it's a little bit easier to understand the definition. All right, so this graph is showing you the percent positive rotavirus tests on the y-axis, and across the x-axis we see the months. So rotavirus is a contagious virus that causes severe acute gastroenteritis in typically children. It's a very common cause of diarrhea. It's easily managed. It's an easily managed disease worldwide, but still we see approximately around 500,000 people, 500,000 children dying from rotavirus each year. And this occurs mostly in developing countries. So we in the US and in most developed, we globally have had a vaccine for rotavirus since 2006. in the US, it's been considered one of the routine vaccinations since 2006. So how do we know how do we know what endemic is? How does this graph help us with the endemic level of disease? If you look at July to November, you sort of see it's a little squiggly, but for the most part, it's flat, right? It's around 9 or 8%. That's the endemic level of disease, right? That's the baseline. In November and through May, we have this huge spike right here. We might say that that's epidemic levels, but before that, July to November, this flat line, that's your endemic level of disease. All right, next graph. So this is showing you the seasonality of hospitalizations for diarrhea among children less than 5 years of age by etiology, so by type, in 17 states for a decade from 1993 to 2003. So on our y-axis, we've got the proportion of hospitalizations. X-axis is again time, so months from January to December. And what I want you to see here is this all is the bacterial diseases. So these are the dark squares. You see how it's kind of a flat line around 9%? This is your endemic level of disease. For rotavirus, well, yeah, let's look at rotavirus again, which is the top, the black line. From July to November, we see a flat line down here. That's the endemic level of disease. Before that, January to maybe May, we'd say, there's sort of a peak. That we would consider an epidemic level. It's higher than normal, higher than the endemic level. All right, what about hyperendemic? When I say hyperendemic, this refers to persistent high levels of disease occurrence. All right, so what's persistent high levels? Let's pretend norovirus, which is also something that causes GI issues, was this red line here. Now, if nationally, and now you guys have to just imagine, just picture this graph a little bit or ignore this legend up here. Now, this bacterial line, let's pretend this is norovirus nationally. So not bacteria, this is norovirus nationally. So nationally, let's say norovirus is around 9 to 8% all year long. That's the endemic level. But in New York City, this red line, let's say this is the New York City red norovirus line, we actually have levels of norovirus that are 12 to 13% all year. We would say that's hyperendemic because it's persistently high levels of disease occurrence. So, and it's persistently high levels in reference to something. So in this case, we're pretending that this bacterial line is nationally. So it's persistently high in reference to the national level. So what does sporadic mean? Sporadic refers to a disease that occurs infrequently and irregularly. So a small outbreak of salmonella we would call sporadic. Now, when the amount of disease in a community rises above the expected level, that's what we refer to as an epidemic. So the occurrence in a community or region of cases of an illness clearly in excess of normal. So this is not, an epidemic isn't limited to communicable diseases. So you can have epidemics of obesity, epidemics of heart disease, epidemics of diabetes. So not infectious diseases, chronic diseases. Right, so an epidemic that you've probably heard of is the Ebola epidemic. This was all over the news last year. And in 2014, West Africa experienced the largest Ebola epidemic in the history of the disease. So just a little bit of background information about Ebola. It's a highly fatal. It's quite fatal. There's 5 different Ebola viruses. 4 of the 5 strains are known to cause illness in humans. One of the strains is only thought to infect animals. That's actually shown here. So 1979, the Ebola restin virus is introduced into US quarantine facilities, only known to infect animals, not humans. Ebola is extremely infectious, but not extremely contagious. So what does that mean? If something's extremely infectious, it means that you can be exposed to an infinitesimally small amount of the virus and get it. So in the case of Ebola, you could be exposed to one virion maybe and get the virus. Whereas in the case of, say, measles, you need to be exposed to a lot of the virus before you would actually get infected. If something is highly contagious, so this is different from highly infectious, that means that you would go on to infect a lot of people. In the case of Ebola, on average, people go on to infect 2 people. In the case of measles, on average, people go on, which is measles is highly contagious. On average, people will go on to infect, say, 18 people. All right, so what do I want you to take away from this slide? So up at the top, we see the years. Oops. Down at the bottom, or the middle green line, so it shows you the number of cases. So again, our definition of epidemic is the occurrence in a community or region of cases of an illness clearly in excess of normal. So most years, right, if we're looking for like why is it moving? 2005, 2006, they're not even on here. 2007 to 2014, we have 0. We would say 0 is maybe our endemic level of disease. Normally, we don't have any cases of Ebola. But if we look in 1976, we have 300 cases. 1979, 1 case. 1995, or sorry, 1979, 0 cases. 1995, 300 cases. 2000 to 2001, 400 cases in Uganda. 2000 to 2001, 57 cases reported in DRC. 2007, 187. And then when we get to 2014, all right, so up until this point, right, the highest number of cases we've seen, I think, is 425 in 2000. When we get to 2014, what you see is we had at least 24,000 cases, and that was as of March of 2015. So that number is probably, I'm sure this graph has been updated since I put these slides together. The number's gone up since then. The other thing you can see here is that the fatality rate is really high, right? So if you look, 280 of the 318 people who had Ebola died. 187 of the 264 people who had Ebola in 2007 died. That's a really high case fatality rate. We're talking about 2/3 of people dying who get the disease. All right, so what about the term sporadic? I sort of briefly covered that. So when you hear sporadic disease, the way I like to think of it is a couple of cases. So Salmonella bacteria usually causes GI symptoms, diarrhea and vomiting, and it occurs 12 to 72 hours after the onset of infection. In some cases, the condition is life-threatening. Generally, we only see 1 to 2 cases of Salmonella. I mean, maybe a handful of cases. It could be more than 1 to 2. But in 2008, we had an outbreak that included at least 1,400 cases. So initially, the outbreak was linked to tomatoes, but ultimately, the epidemiologists determined that it was actually peppers that were being harvested and packed in Mexico and shipped up to the US. So Salmonella cases are usually regarded as sporadic when there's only a handful of them, not epidemic. The 2008 outbreak was considered an epidemic because the number relative to all of other outbreaks, sporadic outbreaks, was so high. So 2008, we're talking about 1,400 versus any other year. So I guess the other thing I'd like to say about this sporadic versus epidemic is I don't really think that the distinction is that important. The Centers for Disease Control has technical definitions for certain diseases on what makes something sporadic versus what makes something an epidemic. For the purposes of this class, what I want you to know, how I want you to think of this is sporadic is a small number, epidemic is larger. So outbreak carries the same definition as an epidemic, but it's often used just to talk about like a limited geographic area. Some diseases are so rare in a given population that a single case, a single outbreak warrants an epidemiologic investigation. So these would include things like rabies, plague, polio, Ebola, any of these, if any case was reported in the United States, then the Centers for Disease Control would go in and investigate. Other diseases occur so commonly that only deviations from the norm would warrant investigation. So these are things like influenza, right? There's always a certain number of influenza cases. In 2009, when we had swine flu, there were so many influenza cases that this was considered an outbreak. So it was more influenza than we were used to seeing. Okay, so this graph is showing you US measles cases by year. So measles was actually technically considered eliminated, not eradicated in 2000. So thanks to the measles vaccination, it's considered eliminated. And it's a highly contagious disease caused by a virus. Symptoms usually include things like cough, runny nose, and sort of the hallmark of a measles infection is what they call the measles rash, which is like a red and white rash that people will get on their body. So since 2000, what we've seen is the lowest we've seen is 37 cases in 2004, up to 668 cases in 2014. Most of these cases in the 2014 outbreak originated outside of the country or were linked to a case that originated outside of the country. So this is also, interestingly, what we're seeing with Zika virus in New York City right now. All the cases of Zika virus have been have originated from outside the US or are linked to someone that originated from outside the country. So in 2014, we had 667 cases reported from 27 states. And the largest outbreak was of 383 cases that occurred primarily among unvaccinated Amish communities in Ohio. So again, you'd have to be unvaccinated to get measles. And most of these cases in 2014 were associated with cases that came in from the Philippines, which had experienced a large measles outbreak sort of right before we saw it preceded the one right before the one we saw in the US. And again, because the world is so global now and it's so easy for people to travel across borders, lots of times you'll see sort of this disease pattern where there'll be a spike in disease in one country, followed by a spike in disease in another country. And it's just because of the way people are traveling. Now, in 2015, we had a sort of fun measles. Well, fun is relative, probably not fun for the people that got it, but a measles outbreak. There was 189 people from 24 states in the District of Columbia were reported to have measles. So that's what this graph is showing you. So the blue states had some measles cases. The gray states didn't have any measles cases. And you'll see it's sort of clustered. The dark blue is in California, Nevada, Arizona, Washington. And that's because these measles cases were actually traced to Disneyland. So the outbreak likely started from a traveler who became infected overseas with measles. They actually think from the Philippines. It was related to the epidemic we saw in 2014. And people who visited the amusement park while infectious then transmitted the measles virus to people who hadn't been vaccinated. And so I see, you guys might also see here that Illinois is sort of lighting up on this map. I don't actually remember right now what happened in Illinois, why there was that outbreak. Maybe it was like another group of school children. If you're really interested in it, let your class discussion leaders know, and I will find out what the deal is with Illinois. But for the most part, all the cases, these dark blue cases we see on the West Coast, were traced back to the outbreak at Disneyland. All right, so what about a pandemic? When you hear pandemic, what does that mean? It's an epidemic that occurs worldwide or over a very wide area, crossing international boundaries and usually affecting a large number of people. So the 1918 flu, which is also referred to as the Spanish flu, was pandemic influenza. We estimate that about a third of the world's population was infected, and the case fatality rate was high for influenza, so 2.5%. So when we looked at the Ebola graph, we saw, just to put this into perspective, we saw the case fatality rate was 2/3, right? So 67%. That's crazy. With influenza, we have a case fatality rate in 1918 of 2.5%. Now, this is high because influenza typically has a case fatality rate of less than 0.1%. And it's estimated that 50 million people died from the Spanish flu. To put this into perspective, 16 million people died during World War I. So more than 3 times the number of people died from the flu. So the other interesting thing about the influenza, the Spanish flu, is who got sick. So if you look at this graph, the dashed line, this U-shaped curve, is what we saw for flus from 1911 to 1917. And what you see is pretty typical for what we see now. So who dies from influenza? The people older than 65 and the people younger than 5. With the Spanish flu, and this is the dark line, the solid line, there's this spike right here in the middle for young people. So it sort of peaks at the 25 to 34-year-olds. That's unusual when you compare it to other years. So the reason people were so scared by Spanish flu is that normal, like young, healthy people were dying from it. It wasn't your immunocompromised persons, the really young and the really old. It was people that we think of as healthy. What's interesting about Spanish flu, well, I guess what's interesting about a more recent outbreak, swine flu, which was 2009, is we saw sort of the same pattern. It wasn't just our immunocompromised, the young and the old, that were dying. It was also young, healthy people, which was one of the reasons people were so concerned about swine flu when it arrived. All right, so I'm going to run through some sort of post assessments with you just to make sure everyone's on the same page. If you want to pause this and try to answer the questions before I give you the answer, that's fine. Also remember, class discussion leaders, if my answers don't make sense or if people have questions, write it down, email it to me. And the other thing I'm going to tell you is that these types of questions are really, really similar to what you're going to see on your quiz at the end of the week. All right, so 22 cases of Legionella occurred within 3 weeks among residents of a particular neighborhood. We usually see 0 or 1 per year. What would you say? Sporadic disease, endemic disease, hyperendemic, pandemic, epidemic? So here the answer is going to be epidemic. And the reason why, and I think it could be easy to confuse this one with sporadic, but the reason why is that 22 cases is in excess of the normal, which is usually 0 or 1. If you chose sporadic here, I would give it to you if you explained why you thought it was sporadic instead of epidemic. All right, next question. Average annual incidence was 364 cases of pulmonary tuberculosis per 100,000 population in one area, let's say New York City. So 364 cases of tuberculosis compared to the national average of 134 cases. So New York City, we've got 364 cases of tuberculosis per 100,000. Nationally, we see 134 cases per 100,000 persons. So sporadic, endemic, hyperendemic, pandemic, epidemic. Okay, so if you thought hyperendemic, you are right. And the reason being is that nationally, the national baseline is 134. What we're seeing in New York City in this pretend one area is 364. So this is more than double what we see nationally. So it's our baseline, but it's a high baseline. Next question. Over 20 million people worldwide died from influenza in 1918, 1919. I hope you just yelled out pandemic. Yeah? Great. Okay, a single case of histoplasmosis was diagnosed in a community. If you said sporadic, or if you thought sporadic, you were right. And again, the way I want you to think of sporadic disease is just a couple cases. So like under 5. About 60 cases of gonorrhea are usually reported in this region per week, which is slightly less than the national average. Okay, and if everyone's yelling endemic disease, you're right. Now, why is this endemic? So we're saying 60 cases per week, so we know that's our baseline, and it's just slightly less than the national average. So it's not lower than the national average. It's pretty close. Endemic disease. Okay, so moving on, more terminology. So what is epidemiology? It's the study concerned with the distribution and determinants of health and diseases, morbidity, injuries, disability, and mortality in a population. All right, so the focus of epidemiology is population-based, as opposed to, say, clinical care where the focus is on the individual. Often you'll hear epidemiology referred to as population medicine. So I put sort of a little table together that's just talking about some conditions. This is an example of how two different professionals would handle lung cancer and salmonella. So an epidemiologist might ask the question, is lung cancer mortality higher in geographic areas with higher pollution? Whereas a medical doctor or a clinician would just diagnose and treat lung cancer in the individual. An epidemiologist might ask the question, is salmonella infection occurring among people eating tomatoes? So again, the focus is the population, whereas a clinician would just diagnose and treat salmonella infection in the individual. All right, the distribution of health and diseases. So what does distribution mean? It just implies that the occurrence of diseases, injuries, disabilities, and other conditions varies within subgroups. So epidemiologic research identifies subgroups that have increased occurrence of adverse health outcomes in comparison to other groups. What does that mean? Down here, I've got a graph for you. This is chlamydia rates per 100,000 populations in New York City in 2014. I took this from the health department data. You guys are going to learn how to use ePquery. You'll figure out how to make these graphs very soon. And what do you see here? So the bottom is showing you by age groups. And what we see is that the 15 to 24-year-olds, 15 to 19 and 20 to 24-year-olds have much higher rates of chlamydia than all the other age groups. So do the 25 to 29-year-olds, the 30 to 34-year-olds. So chlamydia is a disease, an infection of young persons, which we actually know. It tapers off. Fewer people in older age get it. And there's all sorts of reasons you guys could probably hypothesize without me even there, why we see higher rates of chlamydia in young persons. Determinants of health. What do we mean by determinant? So a determinant is any factor that brings about changes in a health condition. So you can think of your microorganisms, your bacteria, and your viruses. You can think of carcinogens, so chemicals such as from smoking. Also toxicology, so toxins that maybe you're exposed to. Exposure, when I say exposure, what I mean is twofold. So exposure could just mean contact with something, so with a disease or a health condition causing factor, such as salmonella, or it could mean the amount of the factor. So actually, let me switch the example to smoking. So you could smoke 1 cigarette a day, or you could smoke a pack a day. So there's a difference in amount there. So when we talk about exposure, just remember that it's twofold. It could mean contact and it could mean amount. All right, health and diseases. These are your outcomes. Health, diseases, morbidity, injuries, disability, mortality. The disease or health condition you're studying. So again, at the end of this class, I'm going to ask you to pick a topic for your summer research project. And you're going to pick a health condition or the outcome you're studying. So this is the result of the exposure. We can think of this as cause and effect. You have your exposure or your determinant, in this case it's smoking, and you have your outcome, your health condition, what you're going to study, the lung cancer. When you hear morbidity, I'm just talking about illness. If you hear mortality, that's death. Now, epidemiology is an observational science. We observe situations. We observe relationships between smoking and lung cancer. We observe relationships between peppers and salmonella. Descriptive epidemiology is sort of a characterization or describing patterns. So Characterizing health conditions in terms of person, place, and time. That's descriptive epidemiology is always in terms of person, place, and time. So I showed you a graph of chlamydia trends by age group in New York City. So the person variable is age groups. The place variable is New York City. Analytic epidemiology, on the other hand, is trying to understand that cause and effect, or the associations we see. So examining associations between exposures and outcomes. Maybe you're looking at the relationship between eating peppers from a certain grocer and developing salmonella infection. So descriptive epidemiology, describing a health condition in terms of person, place, and time. Analytic epidemiology, examining associations, so cause and effect. And again, this whole branch, epidemiology in general, is considered, this is all observational science because we're just observing. We're not going in, we're not giving people a drug that would be intervening. We're just watching. We're seeing if there is a relationship between smoking and lung cancer. Do people that smoke end up with lung cancer? We're not telling people to smoke. We're just watching, we're observing. So keywords, you can sort of be on the lookout to understand if something's descriptive versus analytic. With descriptive epidemiology, you'll often see something like distribution, patterns, describe, trends, person, place, time. Person things being gender, race, ethnicity, age, place being geography, such as boroughs, time could be months or calendar years. For analytic epidemiology, you're going to see terms like association, relationship, between. All right, another quick assessment. You're going to identify which one's descriptive, which one's analytic. And again, class discussion leaders, please, let me know if there's questions here or if things aren't making sense. So if you described the obesity trends by race group, would this be descriptive or analytic? All right, I hope you said descriptive. And the reason being is that you're looking by a person variable, race. So describe, again, one of our keywords, and a person variable, race. If you examined the relationship between obesity and diabetes, you were trying to determine if obesity was correlated or was causally related to diabetes. That would be analytic epidemiology because we're looking at a relationship. Okay, if you examine the number of HIV cases by New York City borough, that would be descriptive epidemiology. You're looking at a place variable, borough, and you're just describing a trend or a pattern, the number of cases. All right, now if you looked at the number of salmonella infections in New York City from 2005 to 2015, is this descriptive or analytic? It's descriptive. And the reason being is that now you have a time variable. You're looking at trends trends in a decade from 2005 to 2015. So we've sort of covered all the descriptive things, right? So in the first one, you see you have a person variable, race. In the second one, you have a place variable, borough. In the third one, you have a time variable, the calendar years from 2005 to 2015. Last one, if we trying to understand if there was an association between bullying and depression, that would be analytic epidemiology. All right, so oops. This semester you're going to be studying, why is it moving? Okay, you're going to be studying risk factors. And a risk factor is just a determinant, we used the word earlier, or an exposure that is associated with a health condition. You can think of this as sort of a cause and effect relationship with a few caveats. So sex without a condom, this is how I want you to think of a risk, is if it increases the risk of something. Sex without a condom increases the risk of pregnancy, chlamydia, HIV. Poor eating increases the risk of, or the likelihood of, obesity and cardiovascular disease. You can also have protective factors, right? Not risk factors, protective factors. So maybe healthy eating decreases the risk of obesity. That would be protective, as opposed to something that's a risk factor. Epidemiologists will generally use the term risk factor to indicate that an exposure is associated with an outcome. Usually that an exposure is negatively, that it associated with an outcome, that it increases the risk of something. But this is really important, and we're going to have lectures just on causal relationships, but a risk factor is not necessarily causal. So you guys have hopefully heard already that correlation does not equal causation. At some point during your time in high school, maybe in a math class. But causality is very difficult to prove. We know that HIV causes AIDS. We know that smoking causes lung cancer. But there's not a ton of things we're completely sure about the causal relationship. We can identify correlations, but again, correlations don't equal causation. And first of all, so why do we even care about all these risk factors? If we can determine which risk factors are associated with which disease outcomes, we may be able to intervene on the risk factor and decrease the chance of illness in the community. So if we knew that smoking causes lung cancer, then you could go out and you could try to get people to stop smoking. Now, going back to this risk factor causal factor distinction, if you also saw that coffee drinking was correlated with lung cancer, you could try to intervene on coffee drinking, but it probably wouldn't do anything because coffee is not causally related to lung cancer. What we do know is that smokers like to drink coffee. So if you were trying to people if you thought that because coffee drinking was correlated with lung cancer, it would reduce and intervening on coffee drinking would reduce the number of lung cancers cases that we saw, it probably wouldn't work out if you were going to try and intervene on coffee drinking. I think I'm talking a little circularly because I sort of lost my train of thought in the middle of this. But basically, what I want you guys to take away from here is that risk factors are not the same thing as causal factors. Correlation does not equal causation. And the example being coffee is associated with lung cancer because coffee drinkers are also more likely to be smokers. If you tried to make people stop drinking coffee to reduce lung cancer, it wouldn't work because the causal factor is smoking, not coffee drinking. All right, so are these causal? Gray hair and Alzheimer's? Would we say that gray hair causes Alzheimer's? No, probably not. Would they be correlated? Gray hair and Alzheimer's? Yeah, definitely. Because who has gray hairs? Grandma and grandpa's. Who has Alzheimer's? Grandma and grandpa's. Gray hair is associated with aging, and Alzheimer's is a disease of aging. And the same for these next two, female gender and depression, being poor, and tuberculosis. For both of them, they don't cause, being a female doesn't cause you to be depressed. Being poor doesn't cause you to get tuberculosis, but they're associated. So in the case of being poor, you don't have access to facilities. You're a marginalized member of society. There's all these societal factors that increase your risk for getting tuberculosis. In the case of female gender, it doesn't cause you to be depressed. It is associated with depression, primarily because women are more likely to seek care for depression. Okay, so the next part of this lecture is going to be the history of epidemiology. I'm actually going to stop recording though, just to make sure that everything's going well. And then I will I'll start a part 2 recording for you guys to start. So actually this is probably a good time if you guys want to go take a bathroom break or just take a 5-minute break. This is probably a good spot for you to do it.